Kirsty. So when I was approached to share cases, it must have been a full moon a few weeks ago. I was on ward service, and we rarely have asthma patients in ICU. And in that week, I had four, so I have plenty to choose from. And I'm going to focus on two that have particular community and ongoing management issues in here. So the very first case, I think, Kirsty, I might just get you. Oh, thank you. Amazing. So we have an 11 and a half-year-old boy, and he's got a Caucasian mom and a Chinese dad. And I think there is something genetically specific about second generation Asians with their risk of atopy. He had multiple admissions for asthma, and importantly, he was intubated in ICU for the management of a preschool asthma at the age of 2. He has a history of allergy to seafood, allergic rhinitis, and he doesn't carry an EpiPen because most of the reactions so far has been pretty minor. Next page, please, Kirsty. Thank you. Oh, thank you. And so before coming to the hospital, he had been on what I would think a pretty highish dose of Flixotide, a preventive medication, in total of 125 to puff twice a day. Adherence is not too bad. I think he does miss a dose here and there, but otherwise it's not a huge issue. He does take as required salbutamol and antihistamines. Of note, his immunizations are up to date, but he hasn't had his flu vax this year yet. So this clinical history actually was quite prolonged. He had 3 weeks history of very poorly controlled asthma with lots of cough and wheezing, and he was using up to 12 puffs of salbutamol, sometimes almost every 3 hours on some days. So he was going to school, the nurses would say, oh, look, I think you need to go home. And then he would continue this treatment in the community. I think he was seen by his GP and was given a course of prednisolone earlier in the illness. A week before coming to our health services, he was seen in emergency locally, and at that point, was given a burst therapy and 3 days of pred. However, he didn't improve. There was worsening wheezy and shortness of breath. He was actually needing hourly salbutamol 12 puff by the time he arrived at his GP's clinic. And rightfully, his GP called the ambulance right away. Next slide, please. So he was initially sent to a peripheral hospital where he was based and received standard therapy on continuous salbutamol and Atrivan with oxygen, IV medications, and then IV ondansetron was given because he was feeling nauseated. And at that point, it was noted in the local hospital that they thought that he was very, very sick. He was peri-respiratory arrest. And at that point, they noted a rash spreading from the arm to the rest of the body. He also had typical wheeze and the symptoms of asthma. So I just want to pause here because this was the point in the acute management that sort of confused us a little bit, and definitely the team that was looking after him. I wonder, would this change or make you consider what the diagnosis may be or change your management? Happy if you unmute yourself. We're not a very big group today, or happy for you to pop it in the chat too. Yep. Yep. Someone say, is it an infective person? And that's a really good point. So we have to consider a child that's been sick for 3 weeks. I think they might be having some fever at some point. Yes. So one of the consideration is this an infection? And I think mycoplasma was considered. The other thought at that point was, is this also potentially an anaphylaxis? Because an anaphylaxis can present in a very similar way, sometimes with rash, with wheezing and cardiovascular collapse. So there was also a consideration, is it infection? Does he also have a anaphylaxis? And that's right. I think the rash really does confound what the presentation was, and having a very sick child make you consider whether there are other diagnoses. Next slide, please. So rightfully at that point, he was given 3 lots of IM adrenaline and started on adrenaline infusion and ongoing asthma management. I didn't put in there, he was also started on ceftriaxone and azithromycin at that point because infection is also another consideration. And really, he responded very, very well. And so I've just cut and pasted what our Piper had wrote when they arrived. At that point, he's really turned the corner. He was looking much better. His ops had improved. So the management, both of his asthma and potentially of anaphylaxis, seemed to have work. Next slide, please. And that was his X-ray. As you could see, there was no pneumothorax. It was slightly hyperinflated, and there was no obvious pneumonia on that initial X-ray. Next slide, please. Okay. So the progress was pretty quick after that. He was in Piku just for one day, came back to the wards with us. He was covered with 3 days of azithromycin just because he's been unwell for a period of time, and there was a question whether this was infection. And then it comes down to discharge planning, which is a lot of us what we do in terms of managing asthma control. Next slide, please. So I just want to open up. I think there's a few issues to consider now that he's going home, around his asthma care in particular. What are the things that, people in the forum think that we should address regarding this 11-year-old boy's asthma control? So he's been on pretty high dose of preventive medication for, I think, a long period of time. It must be at least a year. He's had this 3 weeks history of exacerbation. He's got another very severe exacerbation that landed him in ICU. I think what are some of the things that we need to consider going home? Maybe I might narrow it down. What would be some of the options for the preventer medication? Would he go home on the same thing? Would you consider changing, increasing the dose?
So Libby's taken it off in the chat, Catherine, with a new preventer. What
Yeah,
would you suggest, Libby? I
yes.
know you know the
He's borderline for
answer.
Yes.
Symbicort. And just because of obviously that background of anaphylaxis as well, it gives him that extra little coverage being a dual action. So, yeah.
Mhm.
Yeah, that's a very good point. And that's where I was sitting at too, Libby, because as you say, and this is one of the key points I want to highlight, when you have a young person with a food allergies is extra, extra important to really control the asthma, because we know that when the asthma is poorly controlled, that's when they actually at a higher risk of a severe anaphylaxis. And that was a consideration at the peripheral hospital because we know he's got poorly controlled asthma. Maybe he's accidentally ingest some seafood and perhaps that's flare up an anaphylaxis. So that's a really key point. So we want his asthma to be as well controlled as possible. I also struggle because he's 11 and a half. So with the GINA guideline, given that he's a maximum step 1 therapy on Flixotide, the next step will be adding in a long-acting beta agonist that way. And given that he's 11 and a half, and pretty soon you'll be thinking about moving him to a Symbicort or a smart therapy, which is combined inhaled corticosteroid and a long-acting beta agonist. I sort of discussed with the parents and and discuss both options with them, and they end up choosing the smart therapy pathway mainly because it's easy. It's only just one puffer to carry. He doesn't need a spacer, but it took a little bit of adjusting, which I think some of you will be familiar with. Initially studying they're so used to using salbutamol. It takes a while to get used to having Symbicort as a reliever. So he still went home with his salbutamol, but with the Symbicort. There's a question in there about checking compliance. Absolutely, and that's really, really key. So we went through his technique, his adherence, his dose, and his spacer, and we felt that he was at the higher end of the Flixotide and opted to add in a long-acting beta agonist in the form of Symbicort. Interleukin inhibitors, yes, that was also consider. I think on balance, just with the simplicity of the smart therapy, the family opted to go to the smart therapy. And Kirsty said, other than the GP, could he be referred to? Absolutely. And so the key thing in this family is follow up, right? Just whether what we've instituted have improved his asthma care. So this family was referred just because of his complexity. His original peripheral hospital has booked him in with a pediatrician for follow-up, because the next step, if he has reached maximum therapy, was, as what Libby has said, was actually considered biologic. So we are now, with the availability of biologics and also more experience around that area, how to change the trajectory, disease modifying medications, in children that have reached that threshold, often of referring them. So the pediatrician had that in mind when he came over here. And it's interesting, this family brought up to me because lots of his cousins are on biologics. So he certainly have that genetic phenotype. That's fantastic. Yes, checking all triggers, and environmental was a really big thing for him. He has allergic rhinitis, and we were making sure that he has his Nasonex on a regular basis. So minimizing all atopy. Fantastic. Great, great responses, and great. That was amazing.
I have a
Online-
question for you,
yeah,
Catherine.
Kirsty. Yeah.
As you were going through this, I was looking at this this pathway to disaster that you were describing, and for me as a
Oh, Kirsty,
GP,
you
I'm
might.
thinking, well, he's been seen. So he's in hospital, he's had contact with secondary care, maybe pediatric, maybe general, depending on where he's lived. I think that gives a lot of people in the community a bit of reassurance. So he's been to hospital and they've sent him home. Where was the point in this history that you felt was key intervention should have been instated when it wasn't? No blame. Just at
Yeah,
what point, looking at that, because the
yeah.
retrospectoscope has 20/20 vision and we can learn from it, what point would you have said, oh, see if they had just, would it be GP should have started smart therapy earlier, taken more of a history about the family, the biologicals, been more aware of, all these things can help. Should ED have said, hey, this is actually a lot, maybe we instigate follow up with the GP within the next 2 days, maybe refer to the community asthma program? Which bit, all those things as we've discussed can be helpful, but which bit did you look at looking through the history and
Mm,
think, God, that was the really key point before he
mm.
attended the GP on hourly Ventolin?
Yeah. And that was a very good point. We definitely felt that this was a potentially could have ended up really badly, isn't it? He was peri-arrest at a peripheral hospital. And on reflection, in fact, the parents had brought that up and felt when we redid the education, they actually brought up a really key point. They were not aware when they were using 3 hourly Ventolin, even at that point, he was actually very sick already. And they sat home and sat home. And that was a really good reflection that when he was at that stage, really he should have been, be back at hospital and receiving treatment, going back to the GP, which I'm sure the GP would then send him into emergency. So I think perhaps they didn't recognize how sick he was early on in the illness. I think before this exacerbation, he was having frequent asthma use around exercise, but it wasn't as significant as the last 3 weeks. So I could understand why he hasn't had much change in his preventer therapy before coming into hospital.
So with that, if I've got time, just because I know I've probably bought some time with my case study, I'm just going to try and share this other screen so everybody can look at it just from a GP point of view. I'm sure everybody is au fait with this, but I know it's been useful in the past when we've done symposium. Can everybody see that, the Asthma Australia Action Plan? Yeah, so
Yeah.
when I'm filling this out, and again, sorry if I'm teaching you things you already know, I know a lot of people here experiencing asthma, but this is the point I make in an asthma plan when we're filling it out, okay? When we just jump down to here, to severe, we won't go through all of it, it's not the form for that, but severe is reliever medicine not lasting 3 hours. There's a lot of words in this plan, and it's been streamlined by Asthma Australia. I think they've done a brilliant job, but this bit I sometimes even highlight to really say if the reliever medicine is not lasting 3 hours, you are heading to an emergency department. So I say if you're an experienced family, it's lasting about 3 hours. Let's say it's early in the morning, you can get into your GP and you can be seen, really you're thinking, okay, am I going to the GP first, that relationship with the GP that I can walk in and say, hey, they're sick? Or am I thinking, I'm giving my final 12 puffs of Ventolin, my kid's going to be okay, I'm packing a bag in a leisurely way and heading up to my ED department and saying, I know they look okay, they just had Ventolin, but it's every 3 hourly, we need to do everything. And I say the same if it's 2 hourly. You're given the 12, you're packing a bag, you're heading to your ED. We do not want them down here in the emergency. And previously, the old asthma plans didn't have that. So just if you're not using the updated one, I think for me, that is the most crucial thing for acute asthma care in the community to explain to people is we don't ever want to get you here. I don't want to see you at my door with this. Welcome, I'll help if you come, but you really need to know if you're in this box, you're heading in a controlled manner to ED, not in an AV being intubated. So I'll just head slides. Happy to go on to the next one, Catherine?
Yes, please. Thank you. Perfect. And this is just a slide, just a reminder about discussing when we manage asthma. Really, we want to look at the overall atopy, his food allergies, his allergic rhinitis that we spoke about. And in this instance, we opted to send him home on an EpiPen just because we were not certain whether it was an anaphylaxis or not. I mean, we did a tryptase, that takes a while to come back. So we did send him home on an EpiPen, and I think the messaging is if there's some uncertainty, whether it is anaphylaxis or asthma, I think the safest way is to give both medications as that peripheral hospital did. And that was our messaging to the family when you're out in the community, when you're not sure whether it's anaphylaxis or asthma, give the EpiPen, give the Ventolin, call the ambulance. That's it for this case. Just wondering if there's any other questions before we move on to the next case. All right, well, let's continue on. I say some more sick patients in the same week. So this time, the other end of the age spectrum. So I have a 10-month-old girl. She's really well grown. She's on the 99th centile, and she lives at home with two siblings. Sorry, I've just noted a message about biological safe in kids. I think most of the studies have shown that it is safe and quite effective in kind of disease modifying. The main issue is around the cost of it, and because of that, PBS require a lot of criteria to be met in order to give children the biologics. Of course, we check for infection risk, it's still immunosuppressants. However, in my understanding from the literature and from speaking to Shiv, who manage the respiratory physician that manage most of our biologic, there is not significant side effects that he has seen. Yep, and there's a question about increased obesity. Is there an increase? I suppose the question is whether increase of obesity is associated with asthma. I think obesity has been often listed as a risk factor, although I'm never really certain whether it's a direct cause or whether when you are obese, that also affects your exercise tolerance and you're more likely to wheeze a little bit more and feel short of breath, whether that is the main reason why it exacerbates the respiratory symptoms rather than a direct cause. I'm not very clear. And sometimes it's about differentiating for the child because we really do want, if it's not true wheezing and a fitness issue, I would often suggest to family that they do need to keep up with regular exercise because that's the only way to bypass to actually tackle the problem of exercise tolerance rather than sitting out. Because I found a lot of my children that are overweight with asthma are often sat on the sidelines in schools. I see a few people nodding because the school's afraid to exercise them. They think it's asthma. And sometimes they need some advocacy from our point and say, look, this is not asthma. He or she really needs to participate when they can in the PE. All right, we might just continue on. So now to the 10-month-old girl. She lives at home. She's got two siblings that bring home viruses from the outside. And there are some risk factors in this young girl. So her parents smoke outside, and she only had a 6 weeks of vaccinations at this point. And that's because she's also had a very severe course of asthma. She's had two previous ICU admissions at another hospital with bronchiolitis requiring CPAP, non-invasive ventilation. The most recent one was not too long ago. It was only just a few months back. And she was discharged at that point with a Flixotide trial with the family. And the family was using it intermittently. They were understandably reluctant and uncertain about the role of preventive medication in this young girl. And so they were just using it on an intermittent basis. All right, next slide, please. So before coming to this, before I saw her in this recent admission, she actually came to our hospital 5 days ago. In that presentation, it was a very quick onset of cough and shortness of breath. She was wheezing. She was admitted to a short stay unit and had some high flow oxygen, which is, if most of you are familiar, it's a bit like giving oxygen, except that there's higher pressure, almost like CPAP. It opens up the air pipes, and she was given salbutamol. At that point, again, discussion was brought up about Flixotide, and at that point, our colleague felt that there's probably not much of a role in this young person and advised the family to stop it. But however, booked the family back in to see his clinic for follow-up. And she went home exactly the same day. So it was a relatively short presentation. She recovered and she went home. Next slide, please. So she went home. She's been well for 4 days. And when I met her, she came in again with a very short history of just one day of coryzal illness and very rapid decline in shortness of breath and wheeziness. As you could see when she presented to emergency, she was very, very unwell. She had low saturations, quite a lot of work of breathing. She was lethargic. There was wheeziness and crackly on both sides of her chest. Her capillary blood gas shows a respiratory acidosis and compromise in the ventilation of both oxygen and carbon dioxide. She was started again right away on non-invasive ventilation and was given medications that we typically would use for asthma, salbutamol and Atrovent, and IV medications, but she was also covered with antibiotics just because of how sick she looked. And this is her x-ray. Again, as you could see, it was hyperinflated. There was no signs of pneumothorax, and there wasn't convincing signs of pneumonia on the x-ray. And I think it was mainly bronchiolitis. She responded quite well to the treatment that was given. It was very hard to tell what part of it worked, whether it was the bronchodilators or the CPAP, but she turned the corner quite quickly. She was positive for rhinovirus enterovirus on her swab, and she came off oxygen pretty quickly and was discharged on day 4. So, I see that there is an RSV vaccine question, and we will come to that very shortly. I just want to pause here, and I guess there's no right and wrong answer here. The parents that ask us, is this still bronchiolitis? What would you call it? What should we do? Just interested in what are the thoughts, because this is a bit of a tricky. She's very, very young.
I have a wondering on this, just letting other people put their wonderings in. So previously, until very recently, we always called asthma under 5s viral induced wheeze, or allergic wheeze, or wheeziness because of wheeziness. And we really were reluctant to call it asthma because asthma is a chronic disease, and for all the reasons. We'll move on to that. And really, diagnostically, what we say asthma comes down to a foundation. There's lots of ways to diagnose asthma, is response to bronchodilator therapy. I just wonder, we know that a lot of these bronchi kids then go on to have an asthmatic diagnosis, but that doesn't mean they're going to become asthmatic. I wonder if in another while it will change to calling it all asthma, but just accept that until they're about 8, 10, 12 months, they might not have the receptors that Ventolin responds to. But is it still the same disease process? Are they kids with reactive airways, with an inflammatory response and bronchoconstriction? And how we understand asthma will change, because it does seem ludicrous that at 1, or once they develop receptors, we're now calling them asthmatics. And in the same way as the kids who don't really get bronch after 12, we don't call the 3-year-olds who don't really get asthma after 3 not asthmatics. Does that make sense? I wonder if it will change a bit, and just what we define asthma as, and the phenotypes of asthma and the triggers for asthma will become more prevalent, rather than nomenclature and Ventolin responsivity in the small people, obviously.
I think you're on the right. I definitely how we feel in the hospital. It is a little bit tricky in this one. However, I guess we have to think about what happens, when she wheezes again. There need to be some kind of action or plan to give to the family, isn't it? And she did prove that there's some response to salbutamol, and she was very, very unwell. So I think we explained the nuances to the family. It is virus trigger, and she did respond to salbutamol, and therefore, yes, she's got preschool asthma, and there's an action plan of what need to be done. And given how quickly she deteriorates, really she needs to be getting medical care quite earlier on with her illness. Yeah, so it is one that was tricky, but the family need to know what to look out for and what to treat her with, because chances are this is not going to be her very last time wheezy in the setting of a viral illness. Can we go to the next slide?
Yeah,
And then
sure.
we may cover some of that vaccine things. Right. And then therefore the question is, she's been in a 10 months. This is a third ICU presentation and fourth hospital admission in a very, very short period of time. So there was a lot of discussion on how we can prevent a future admission. And someone brought up an RSV vaccine. And I'm just interested in the community, whether this is something you would offer to this child, because this is pretty new to us in the hospital too.
If anybody's got experiencing, so Libby said, yeah, anybody's got
Yeah.
experience of already giving the vaccine, the monoclonal antibodies, just pop down what you do. There is no right and wrong answers. We're all learning here.
Yeah. Yeah. Yes. And we did offer the family the RSV immunoglobulins. And you're all very familiar. This has only just been rolled out in April. So for the pregnant mothers, it is a vaccine. So it's part of the virus to create immunity. And there's memory and immunity. However, in children, that's not licensed. In children, at this point, we are licensed to give Nirsevimab, which is a long-acting immunoglobulin, so passive immunization. It lasts about 5 months' time, so it's not a lifelong by any means. It's not an ongoing protection. However, she does meet the criteria. So for children heading into their first or second RSV season who's at high risk, and that includes severe asthma is one of them, genetic, respiratory, cardiac, chronic kidney disease in children, are all eligible to get the Nirsevimab, which is the long-acting immunoglobulin. So we did offer to the families. They were quite against vaccine. The impression was every time she had the vaccine, she got sick. And I think it was just coincidental that she picked up lots of viruses and she got so sick rather than the vaccine causing it. So out of all the vaccines, they were very much open to the RSV vaccine, given that we're heading into winter. And I think this would be a patient that I would offer it to. Okay, that's it from me. Any other questions? Oh, so we did also discuss about the Flixatide, and that was really, really tricky because given how unwell she had 3 ICU admissions. It was something that I offered to the parents. And I said, look, it's worth a trial. You've been in hospital for so many times. And we had a defined period. Let's say, let's try this winter period and see whether that made a difference. I'm not sure whether I fully convinced the family, and I'll follow up with my colleague what they decide to do. But I did offer them an action plan with the Flixatide as a regular preventer. We also address smoking, which I think as GPs you're more familiar with us regarding the process of engaging the family in that conversation. Perfect. Any other questions?
Okay, thank you so much, Catherine. It's really great to hear it from the other side as well, and what we can be doing better to prevent these things happening. On that, my case study is from sort of the other way, not having a diagnosis of asthma, but with a symptom. It was suggested by the working group because we had a lot of feedback after our asthma symposium last year that people still really, really struggled with differentiating cough and cough variant asthma. So I think a lot of people are quite comfortable if they hear a wheezy kid, whether it be bronchiolitis or asthma, depending on age. But the presentation on cough in children is frequent and it's difficult. And as everybody knows, in primary care, we get handed a symptom. So I'm going to go through this case, which is an amalgamation of multiple patients of mine who have presented with cough. And then again, not wanting to teach people what they already know, but I'm going to work through how I would work through it and my differentials, ending up with the diagnosis of asthma. I think sometimes going through knowledge that we kind of know together in a forum with a multidisciplinary team, with the benefit of having asthma specialist nurses, pediatricians here, we can work through really, are we all on the same page? Do we all work it through it in the same way? And are we going to definitely hang our hat on asthma, or is it something else here? So this is a 6-year-old female and she does have asthma. Okay, we know this. She was diagnosed age 3 after an acute admission to hospital, and she had a bit of an unstable preschool period and required a low dose Flixotide for about 18 months. And at her review at 5 in our annual asthma plan, she'd been stable for over 6 months with kind of no symptoms. So we'd reduced and stopped her Flixotide, and the family said she was stable since. This is a kid that you know well, you know the family, you see her for other things. So she's been in your awareness. You've just not seen her for her asthma in a while. And as far as you know, the asthma is pretty well controlled, pretty typical GP thing. You know, her asthma's plan is in place. You did it just the beginning of the year. And really the family said, we're only ever using it occasionally in illness, spring, probably less than 5 times a year. A couple of puffs seems to settle it. All seems fine, doc. Parents weren't that clear on what symptoms trigger them for the Ventolin use, though, mostly noisy breathing or waking at night and asthma. But she's certainly not had any prolonged symptoms, nothing that would make you trigger any more education. They've been to the community asthma program. This is a family that you consider has had a decent amount of asthma. The kids growing out of it, they're pretty stable. With the knowledge of her history, you're looking through her notes before you call in, and you can see she's still on her Ventolin as required. She often gets an antihistamine as required. She's got an allergy plan and an asthma plan for school. She's allergic to penicillin. She had hives when she was little. And she's got atomy eczema and hay fever. She was a preemie and she had brief ventilatory support. She was followed up until she was 2 and then she was fine. There wasn't much there. And she is obese. She lives with her parents and brother, and she's schooled locally. You know the whole family. You know that dad smokes out with the house, and you have chats about it from time to time when he comes in. They've got a cat at home that they've had for many years, and you know that they went to Samoa 3 months ago. For 6 weeks because mum had come in to ask about it. So this girl presents and mum says, look, she's had this cough for about 5 weeks. It's autumn, it's this time of year. And mum's been using the Ventolin most nights, but she's just not really sure if it's helping. She doesn't, it's not like her previous asthma attacks when she's been breathless and wheezy. The cough started shortly after she came back from Samoa, and she seemed to have usual cough and cold symptoms in first. That sort of settled, and maybe she's had another bit of a runny nose and a bit of the sniffles, maybe a bit of a sore throat, but not really sure. Typical sort of 6-year-old stuff. She's coughing and she can have noisy breathing, doc. Not sure if it's wheeze. She does cough during the day, but not as much, and she's at school most of the day. They've not mentioned too much. Sometimes it sounds wet, but she's really tired from coughing. She's falling asleep during the day. The teachers have said that, and you've been saying, yeah, she's been having a pretty hard time at night. This is a family who they've got a good relation with the doctor. They don't come in a lot, but they come in enough so you know them, but they don't like to bother you. They're not offering up too much information. They kind of don't want to darken your doorstep. Very grateful for everything you do. So we're thinking about this little girl who's had a prolonged cough. She's got some symptoms like she's tired from coughing. She's had some travel. We know she's atopic. We know her dad smokes. She's got a cat at home. Maybe she was infective at the beginning of it. Maybe it's an asthmatic cough. So where are we going to go from here? Kids presented with cough. We're going to work our way through an algorithm of what sort of cough can this be. So obviously ones for me in practice and what I hear a lot of other people is the recurrent urti in this age group. So kids this age can still have multiple urtis every 2 to 3 weeks. Not maybe quite as much as the 3-4-year-olds, but I certainly still have somebody who starts school and preps and they get the recurrent, new group of kids, recurrent group of urtis. And it's really hard when you've got a couple of kids and you're busy keeping track of them, especially if they're not specifically unwell. But really with this, we're looking for periods of clear coryza and unwell with a cough. It tends to improve quicker than 1 week, but it can last 2 or 3 weeks symptoms. One of the main things I've got from speaking to Shiv, who does the complex asthma clinic, is a lot of asthma care really isn't rocket science. It is really pinning people down on an accurate history. So this is one of the first things I do. She may or may not have had infective, it's clearing, and then she's getting worse. Or is this just a chronic nocturnal cough? Is she having the nasal congestion, the runny nose, the mouth breathing with PND symptoms? Is there an absence of breathlessness, work of breathing and wheeze? She's relatively well during it, so she's not seriously sick. And there's no response to Ventolin, mum says. So when you're looking at these kids, they tend to be well, lots of nasal symptoms. They tend to be the sniffy kids, lots of nasal symptoms, and no real signs of asthma. So what do you do here? You're still not clear. I guess this is something I sometimes say is when they're coughing at night and have this noisy breathing, get a video of it. I think it's rare to hear wheeze without a stethoscope, without signs of some form of increased respiratory effort. And that's different from the grunty upper airway noise. So I really find getting a video of it. So I used to say, tonight, just video her sleeping. What is this noisy breathing that we're talking about? Often as well, if they're coughing a lot, I say sit upright and give them a drink and see if it clears their throat. See if it's just all catarrhal. And if it clears their throat, then it's not asthma if their cough stops, okay? We know that asthma won't respond to a warm drink. I do a similar thing with exercise, okay? Stop them exercising. If their breathlessness stops, it's not asthma, okay? It's fitness. That's from different topics. But so see if that helps. And also with the recurrent urtis, I really encourage parents of asthmatic kids who are struggling to define what is a recurrent urti and what is asthma, come in. Okay, we have the luxury of bulk billing our kids, but I say bring them in, bring them in, bring them in, bring them in every single time, so we can really listen to our chest and clarify, does this just seem to be a kid with recurrent urti and it's a wet cough and it's just at night because they've got postnasal drip, or is this asthma? The other thing is getting videos of the coughing. I think most people will be quite familiar with the difference between a wet, crackly upper airway noise cough and a dry cough. And these things seem quite labour intensive, but actually everybody's got iPhone. I often get the parents in with a video first place as well to listen, and I find it really helpful. It's a simple thing. The last thing is, if you're not sure in an asthmatic patient, it wouldn't be the wrong thing, and we'll go on to what we do if we think it's asthma, to trial putting her back on her Flixotide again. Okay, sometimes in this kid, we don't know. Okay, you're not there at night, you can't tell. So that would be the next thing. If I couldn't decide after all these things, I'd be like, look, I'm not sure. Let's try her back on her Flixotide and see if it helps. Any questions about that first? I know it's quite a simple thing, but I think it's something that comes up a lot, and it's a lot of the questions on our symposium was, how do you determine? And just to reassure you, everybody's got the skills. It really is that detailed history taking and those little bits just to give you an idea of what it's like for those parents overnight. Is this asthma, or is it just recurrent coughs and colds? Second thing, we've had a kid who's travelled. We've all seen those kids who have come in with bacterial infections who just aren't that well. It's just an indolent bacterial infection. Obviously, if they come in with a raging fever and breathlessness and chest signs and they've travelled, you can pick it up. But sometimes you just see those kids at week 4 or 5 of cough, and actually it is just an indolent chest infection. So again, not teaching everybody what they already know, but I'm looking more for that productive or chesty cough. Harder in little kids because they're almost always snotty, but by 6, almost always they can expectorate, okay? Signs for me that I'm worried about are fevers, upper abdominal symptoms. I find pneumonias and atypicals, so nausea, vomiting, upper abdominal pain. And the key for me, a child who's not got an acute illness, is she's not presenting with acute flu or acute RSV, it's 5 weeks. They just have that pallor of a sick kid and they are not hungry, okay, in a change. And for me, and again, I'm sure you're all very experienced physicians, but these things really, for me, make me go, we're not acutely unwell. It's been weeks. Maybe we're thinking about something more significant. Examination signs that I'm always suspicious of. Tachycardia in a kid I know, not an anxious kid, isolated tachycardia without a fever, I don't like, okay? Tachypnea is something I often see in kids with pneumonias and atypicals. They seem well, maybe they don't have a tachycardia or fever, they just have that very shallow breathing, again, pale, off food. So really doing your OBS really well. Hypertensive and fever, I think everybody's going to know that. And the clear thing for me, which often tricks people out, is no chest signs. The amount of kids, I would say kids with pneumonia, I hear less chest signs than kids with influenza or a little chest infection, because they've got consolidation. They don't move as much air as adults. And often I really don't see many chest signs. And with or without asthma signs. Obviously, a child can have a bacterial infection with asthma signs, or the asthma signs kind of settled, and then you're thinking, okay, so is this pneumonia? And I've had several patients last year, this year looks like it's going to be a big pneumonia year as well, where they've come in with asthma, infective, they've responded, we've said it's viral, their asthma's got better, and then in the 2nd and 3rd week, they're presenting more like this. I don't feel well, I'm not eating, still feel hot now and again, I've got some chest discomfort or upper abdominal pain. And again, there's just, remember, little people compensate, even in teenagers, young adults compensate, and they're just tachycardic. Blood pressure is a bit lower than usual. I'm reminding in primary care, we really don't do blood pressure in children, so it's worth doing. In these kids who just seem sick, end of the bed test, they've failed. I'm doing a viral swab and PCR, the COVID and atypical bacterial PCR. If they can produce some sputum and sending it, I would start first-line antibiotics in this kid that day and consider a chest X-ray covering for atypicals if they're not responding in the first few days. Any questions about that? Just to let you know, there is no answer in this case. It's a choose your own adventure. So this is just all the ways that she can go. And these are all, every presentation is all from asthmatic patients I have seen who have presented with these. So one to think of in a well child in talking about atypicals is whooping cough. I'm sure everybody has had the plague of whooping cough in the last 6 months. So this is, again, could be this kid, protracted cough in a well otherwise child. Is it asthma or is it actually whooping cough? Really tricky when they come in at week 5 or 6 with this cough, and almost every single patient who I felt had whooping cough in the last 6 months did come in at that point. So this, you can read that, I'm sure you all know the phases of whooping cough, but really this non-persistent, non-specific persistent cough. In smaller children, you can get perfusion and weight loss and sleep disturbance. Other family members, so in your history taking, you're really saying, have you all had this cough? And what you're really looking are these paroxysms. I don't remember the last time, I don't think I've ever heard of whoop, to be honest, maybe in secondary care. Catherine, do you ever hear kids whooping with whooping cough? No. So the whoop that you all learn, don't look for it. It's paroxysmal coughing. You're fine, and then you have this coughing attack, vomiting afterwards sometimes, but this real unable to stop coughing.
I think the recent bout of the most of us are seeing whooping
But
cough.
again, it's
Have
the
been
history
really
of
hard to
exposure.
tell.
Has whooping
I would say it's just because a lot of them have been
Yeah.
modified in some way because they have had the vaccine. It can be very hard to differentiate from just your extended infective cough. We've been caught out a few times of coming back with whooping cough when we have not suspected it at all.
Yeah. So it comes across, and if you look at the advice on identifying whooping cough that comes through from the government ages, suspect whooping cough in anybody with a cough and a runny nose. And you've always got to remember, but it's a difficult one because it always needs to be in your mind, because really there's nothing you can do at this point, is the point of this. You have to take the history of, did everybody else have it? Because if somebody has it, likely 70% of the household contacts have it, but also has it gone round school? Okay, do you remember an email a few months ago saying it is it gone round school? And really, my advice is saying, look, expect this. It can be the 100-day cough. We can be 3 months here. Make sure you've excluded all the other things. And again, if you're not sure, fine to try the Flixitide again. Can be tricky because by the time the Flixitide's improving, the whooping cough may be improving. But I think to hammer home, under-treating a child with asthma with Flixitide for 3 months is potentially worse than giving them Flixitide for 3 months. So just a point on very typical TB. Kids with TB don't really present with this. They usually present with lymphadenopathy. It's unlikely you're going to see it, but just remember the travel history. The other one that I wanted to put in here, so high index of clinical suspicion. So when you're in Samoa, did anybody get hospitalized with TB? I remember to get a chest x-ray and a lateral. Really at that point, I'm referring into hospital and calling the ID team at the RCH. The other one which I'd put in here, which I didn't make a slide of, 6 less likely, but malignancy. I've had this in a patient, unfortunately, asthmatic, coming in, persistent cough and breathlessness, not responding to reinstating their preventer, and then developing quite acute nocturnal dyspnea. So sending in for a chest x-ray and having florid bilateral hyaline-lymphadenopathy, cardiomegaly, and pleural effusion. So yeah, just to remember that rare things are rare, but do check if you've got a child, again, who seems to be pale, nauseated, unwell, has a history, and things aren't responding to your asthma treatment. Think of the odd things. Common one, chronic rhinosinusitis. So predominantly this kid is coming in and they're the nasal sniffy kids. So you're really looking at your nasal symptoms and post-nasal drip. You're examining their nose for inflamed turbinates, polyps, and absence of asthma symptoms. They can have asthma symptoms, but if this is a chronic post-nasal drip because this is a chronic rhinosinusitis patient, then giving them Ventolin Flixitide won't help, but a trial of a nasal steroid, Avinus or Nasonex, and reassuring that they really need to be doing, I usually review after a month, but a 3-month trial, the safety of intranasal steroid in terms of long-term side effects. And also sometimes nasal steroid can help with their asthma symptoms as well, which we'll move on to. So if you think this is more chronic rhinosinusitis, you can try nasal steroid, but you need to give it enough time. That brings us to other upper airway pathology. This is an overweight child who's nasal, and her parents have said noisy breathing. Do they mean snoring? Okay. Have they got an adenoidal voice, large tonsils and adenoids in the examination? Is the breathing actually snoring? And not only do they have postnasal drips, but they've got apneas. Okay, so remember that if they're having a chronic cough or nocturnal symptoms. Obviously, in examination, you're looking for the typical sleep apnea kids. And again, really, you're thinking again about nasal steroid to see if it helps the airway obstruction, or an ENT referral if this is becoming a more chronic problem and apneas are present. Again, videos. I'm rattling through this because Maria Deb's got to speak to her point. So GI, less likely in smaller kids. I see it a lot in teenagers and slightly older kids, but chronic nocturnal cough. Had this kid in today, had her in 2 weeks ago. Actually reflux symptoms. So always remember, if you suspect that, again, maybe you've treated them for asthma, it's not working, is it do they have typical reflux or additional GI symptoms, loss of appetite, upper abdominal pain, globus, dysphagia, chronic sore throat? Consider, have you treated the other family members for Helicobacter pylori? This is this kid that I've seen in the last 2 weeks. They've all had Helicobacter pylori. And overeating, so again, think overeating, eating late, poor nutrition, and fasting. I often get kids in after Ramadan who have got reflux symptoms. Examination, you're not going to notice anything really, but absence of asthma symptoms is obviously one. And then you're thinking about lifestyle factors, weight loss, and a trial of a PPI. Obviously, you're doing Helicobacter status. If it's chronic, iron, hemoglobin, celiac is another one to think of. And then more into the asthma categories, so allergies. So something we see a lot is uncontrolled allergies causing cough. Okay, so you've got an atopic kid here. We get a high incidence of asthma in atopy over. Australia isn't like other seasonal countries in the world. We get a lot of flowering plants. I think the leaves coming off the trees make a difference, but we've just had a huge surge in asthma and atopy recently. But you're looking for the other allergic symptoms in history and pushing for that. Looking on examination for conjunctivitis and the nasal symptoms, and they might have asthma symptoms as well. Remember, they might be wheezy as well. With a particular child I'm thinking of, it was predominantly cough, no breathlessness, no wheeze, and actually just reinstating their springtime nasal steroid and daily antihistamine and following up the follow week, the cough had settled. It was all allergic. Some people's mild asthma will be controlled with this if they're still coughing, but their allergy symptoms of conjunctivitis and nasal symptoms and sneezing have settled. Again, I would be thinking about starting the Flixotide. Okay. As required Ventolin if they don't have a chronic cough. And again, I usually review after 1 to 2 weeks to see if it's settled. And if all the other symptoms settle but the cough ongoing, then treat as allergic induced asthma. And remember to do an allergic rhinitis action plan for school. That's really important. We're often really good at allergy plans in asthmatic kids, but the allergic rhinitis plan is separate, especially if you're going to use nasal steroid and antihistamines in case they've forgotten it in the morning. So this is slightly different in terms of allergies, not hay fever, but environmental. So you're asking, is it the cat? Okay, is that a new cat? Do you need to get rid of the cat? Damp, so I was asking about housing and chronic cough. House dust mite, you can't ask, everybody's got a house dust mite. If anybody's got any good ideas in the chat about how you can identify whether it's house dust mite, I'll get onto what we do to test it. But really with these, you're looking for a worsening atopy. How's her eczema? How's her allergic symptoms? Is she getting hives with this chronic cough? Examination for other allergies in asthma, often none. But again, nasal symptoms, conjunctivitis, eczema flares, and again, you may or may not hear her with asthma symptoms. If you're confused and you think, okay, maybe it is because you got the new cat, maybe you did move and it's a damp house or house dust mite, you can do a RAS to support the diagnosis and try and reduce an exposure or remove the trigger. Trialing the nasal steroid. Again, there's a running theme here in the antihistamine. And again, stressing the safety of long-term intranasal steroid, using the as required Ventolin, and again, assessing after 2 weeks of these to see if it's improved at all. If it's not, we're thinking about our Flixotide again. Which brings us on to asthma, okay? We've excluded all these things from the history, or we've included them, we've trialed them, we've not trialed them, or just from the history, you've decided, nah, this is asthma, okay? So obviously, if there's accompanying shortness of breath, work of breathing, or wheeze, we're going to be thinking it's asthma. The dry cough, which a lot of parents know the asthmatic cough. If you trust they know that, they've a good education, or get a video. Obviously, predominance of overnight, early morning, but that doesn't mean that it can't happen at other times. And this is where I really go into the other triggers of cough. It's very unlikely that she's just got a nocturnal cough from lying at night. They probably are coughing in cold weather, temperature change, wind, exercise. So really say, is there any other time that you're coughing? And if there's coughing in any of these things, I would be thinking, okay, that sounds much more like asthma. May have coexisting infective or allergic features as we've discussed, and you have to treat them. And with cough predominant asthma, there can be a full or partial response to Ventolin, and some of them don't seem to respond to Ventolin that much at all. Cough predominant asthma, often there are no symptoms, they're well in between. And when we look at the GINA guidelines, they comment this on cough variant asthma. They don't have specific guidelines for it in isolation, but they do recognize that often there is normal spirometry. So you've got this kid with this chronic cough, you're not sure. You can consider spirometry, usually over 8 years old, which can be useful, especially if there are other asthmatic symptoms and you're wondering. But usually if it's just the cough, the spirometry can be normal. So in this child, if we think it's asthma, I would be restarting an inhaled corticosteroid once more, back on her Flixotide, 50 micrograms, 1 puff BD, or thinking, are we going to change her to Alvesco once a daily just for ease of delivery? We know she's responded to Flixotide. She's been on Flixotide in the past, so I would probably choose this first line, unless the parents say, actually, it's a pain in the neck, it's hard to give, we'd prefer a once-only therapy. It's really a discussion. I'd be reviewing after 6 weeks to give it a decent time to effect, and consider weaning it if she's had 3 months of good control with no exacerbations and minimal Ventolin use. You can ignore that bit. So just to go through that and where this can sometimes become confusing with cough predominant asthma. And again, this is focusing on cough predominant because I think we've talked a lot about typical asthma in other slides. If we look at the new GINA guidelines, and again, I'll focus on the 6 to 11-year-olds, is very much based around traditional asthma. So symptoms less than twice a month is your low-dosed ICS taken whenever you take your SABA. Symptoms twice a month or more, but less than daily, is a low-dosed inhaled corticosteroid. And symptoms most days or waking with asthma once or more a week is a low-dose combination ICS LABA or a medium-dose ICS. And this is where I find cough predominant asthma difficult, because this child's in this category. She's got symptoms most days, but she isn't wheezing, she isn't breathless, she just has this dry, irritative cough. I was discussing this with Catherine before. My take is that we start her on a daily low-dose inhaled corticosteroid because she has daily symptoms. This won't work enough because she's got daily symptoms. And this is probably overkill because she's not breathless and wheezy and having symptoms and other things. So this is sometimes where we have to interpret the guidelines and think, okay, there's really no wheeze, there's really no breathless, this is just cough asthma, or think maybe there is an URTI there, but we're managing it. We're starting the low dose daily inhaled corticosteroid. Don't be tempted to go gun-ho and start up here or down here. Would you agree with that, Catherine, Libby? Is that what you're doing in practice?
I agree. I think a lot of work, as you have described, is trying to differentiate and whether you think that they are symptoms consistent with asthma, because I guess you have to balance out the risk and benefits of the medications you're using.
Yeah, and I think that's a discussion with the parents as well, just to say sometimes be honest and say cough can be complex. These are the things that we've screened for. These are the reasons why it's not this, you know. And the main things I find is people wanting, do they need antibiotics and do they need their asthma medications? But very rarely do people consider allergies or environmental allergies that it could be. So I think just having that discussion and saying, okay, side effects, but trying it for 6 weeks, really on risk, they're not going to have too many side effects. And that is long enough to see, is the cough actually going away? Is it controlled now? Making sure that you're changing their asthma plan to reflect that, explaining that if this is cough asthma, just because we're dealing with cough now, that means her airways are more reactive. So be very wary of increase in other asthma symptoms, increase in allergens, increase during exercise, and that we're treating this as reactive airways. Yes, it's presenting with cough more than its traditional presentations that she's had in the past, but just to be really, really aware of all those other symptoms and making sure that you're treating them well if they do come up. Libby.
I just had a question.
Yeah.
With that step 1, the low dose ICS taken whenever SABA is taken, that's not something that we ever really use in or would talk to families about. Is that something that you guys ever really see in your practice, like, or would advise? Because I
I
would
don't
find that
do
confusing
it.
for families.
Yeah, I don't do it. And this is why I showed this slide, because if you're looking
Yeah.
for advice, and you
Yeah.
go to the GINA guidelines, this is,
Yeah.
and I think this is where this emerging sort of evidence on asthma is. So just
Yeah.
I haven't got the 12 plus. If you haven't looked at, look at the GINA guidelines 12 plus. We use
Maybe you're cutting out a little bit there.
oh, am I?
Yeah.
Yeah.
Oh,
That's okay.
is it any better now?
Yeah. All
You're
good.
back.
Yeah,
Yeah.
so
Yeah.
most people will be familiar with smart therapy for adults.
Yeah.
Just a brief rundown, we're using it in 12 plus now. And as
Yeah.
Catherine said earlier, from 10, 11, nearing 12, often we'll move to smart therapy if they're really bad and you think it's warranted. Speaking to Shiv about this, he is actually using smart therapy in this age group for the appropriate unwell children. So he is using it lower and lower. And basically, the GINA guidelines say there is ongoing research into whether it also should work in this group. So a bit like what we were discussing with bronchiolitis earlier, it's not that it doesn't work, it's that there's no evidence base for it.
Mm.
So it may be
But
that
like, it
another
wouldn't
5
be,
years we're doing this for this age group as well.
yeah. But
But
like,
it's
do you know what
not
I'm
what
saying? Like,
any
if
of
it
the
was a
guidelines
child
we
on
are.
Flixitide and they weren't on it, so say they're having symptoms less than twice a month, and so they had it at home but hadn't been using it, but then just had a couple of symptoms that month. Would you suggest to the family then to try that Flixitide with their Ventolin? Do you get what I'm saying? Like, it's not.
You're right. And it's not
Yeah.
something we have fully implemented. We know that this has
Yeah.
been in GINA for a while. It's been
Yeah.
hard to implement because the evidence isn't there. It's on in
Mm.
progress. But also practically, I find that quite tricky because you have to
Yeah.
carry your Flixotide wherever you carry your Ventolin, and then you have to go
Yeah.
brush your teeth or rinse your mouth out. So for those that
Mm.
are more difficult to control, we have
Mm.
moved them to a smart therapy at a younger age and therefore had done the step one. So they are using just one inhaler, which has a
Mm.
combined inhaled corticosteroid,
Yeah.
the long-acting beta agonist,
Mm.
rather than making them carry two, which I think can be quite hard to implement.
Yeah,
Yeah.
definitely. And I think another confusing thing I know from when I've read the GINA is that with like fluticasone, for example, it can take up to 4 weeks to get to that optimal dose in their, do you know what I mean, in their airways. So telling them to use it ad hoc, like, it's conflicting. Do you know what I mean? Like, it's,
I think it
yeah,
highlights a really important change in asthma understanding that we're going through. And I think
yeah,
that's what we've been talking a lot about in the last 2 years. As that, yeah, Mel's just the same.
yeah,
It's saying our understanding and our basic asthma knowledge is being challenged and changed, but these things take a long time to be adopted into practice. So if you think
mm,
about the basic pathophysiology of asthma, it's an inflammatory disease, and your
mm,
SABA will relieve the symptoms, but it doesn't do anything to alter
get
the
rid of the
disease.
inflammation.
And the
Yeah,
idea of using the SMART
mm,
as required is if you
mm,
have respiratory symptoms, asthma symptoms, you don't just have bronchoconstriction, you have active airway inflammation.
mm,
So taking a
absolutely.
small dose of steroid with your SABA helps. So it kind of holds that why would that pathophysiology suddenly occur in 12-year-olds and not from 6 or
Mm,
from younger ages? And that's where there's not the evidence base and we don't have the pathophysiology. Not, we know that Ventolin receptors only develop at a certain age, but there's no hard and fast rule there. It
no,
might be
no,
6
true.
months, I don't know, for some children. It might be 12 for others.
Yeah,
It'd be really interesting to know, Catherine, if there is, the hard and fast rule of that. But I'm also aware of time, actually, and we need to get onto Deb's
yeah.
slides. Okay. So yeah, any more questions, just pop them in the message board. And Deb, sorry for cutting into your time.
All good. I'll move through this fairly quickly, I reckon. So, Kirsty, can you keep sharing your screen?
Of course, yeah. I'll let you
Sorry.
introduce yourself.
So I'm Deb Hartson. I'm one of the registered nurses who is a care coordinator for paediatric asthma and eczema at Sunshine Hospital. We work in the division Western Health at Home. We're very similar to what CAP do, the Community Asthma Program with CoHealth and with DPV. Two of my colleagues are on here tonight, Naomi Swan and Katie Caradice. So I'll go through a case that I worked with this family actually last year, and he was a little boy who was 4 and had asthma, preschool asthma, since he was 2, youngest of 6 children, and the parents were from a non-English speaking background. Dad had some English, mum struggled. So there was a great need for them to have an interpreter. So before we had our referral over the 6 months, he had 4 ED presentations and was admitted each of those times to Sunshine Joan Kerner. And besides the burst therapy and oral prednisolone, on 3 occasions, he'd had IV mag and methylpred. So and each of those presentations came in as a CAT 2, felt to be late presentation. Hadn't had ICU before, was known to the Royal Children's that had a few ED presentations there. On history taking in the notes from EMR, mum had reported in between the episodes, he'd had increasing symptoms and use of Ventolin at home. Sleep was interrupted. He was missing kinder. They'd actually, in previous admissions and on discharge, asked the family to start Flixotide, but they had stopped it when the child was well, which is interesting considering what we've just spoken about. So they were referred to our community asthma program. And I just thought I'd, quickly, especially considering time, just run through a few of the things that were the key issues and what we did. Kirsty, thanks. So he had a reported egg, lentil and pea allergy, had never seen an allergist, wasn't anaphylaxis. He actually had a vomit after he'd eaten those 3 things and developed a rash. The GP had made a referral to the RCH allergy clinic, according to mum, and had given an allergy plan for kinder. Mum had a bottle of Zyrtec at home and one at kinder. He was immunised up to date. The GP had actually spoken to mum about the flu vax, but she felt quite hesitant when I visited her. He had a history of eczema, seasonal hay fever, and the whole family were fairly atopic. His triggers were when he had a viral urti, weather changes, season changes, when he played vigorously, and very typically when he had a good tantrum or was wrestling with his brothers. So he went to kinder 3 days a week. And interestingly, what happened was that the parents on enrollment with kinder hadn't told the kinder about his asthma, and then did take an asthma action plan to kinder to let them know he'd been in hospital. And of course it wasn't signed, and they hadn't turned up with a spacer, mask, Ventolin to give the centre, so the kinder refused him to come back to kinder at that stage. And Kirsty, if you can go to the next slide too, thank you. So just a few of the key issues that immediately, popped up was, checking mum's health literacy, her confidence in problem solving. The late presentation to ED needed to be addressed, and we're very lucky we have access to interpreters that we can take into the home. And I had an amazing older lady who was an Arabic interpreter, and I used her for every visit. We kind of organised our visits around when she was available. So then, you can be unhurried and explore, their beliefs and barriers in the home. And on asking mum, what was important for her was that she was missing her English classes that she really enjoyed and wanted to get back to them. So, I needed to establish whether the Children's Hospital actually had received that allergy referral. He was 4 starting school the following year and this year, and I wanted to make sure that he had that sort of allergy follow-up before he went to school, which is valuable because they can kind of get a bit of a cleaner bill of health and be up to date, so that if he's grown out of his egg allergy, they won't need to pop that onto the allergy plan. We address the flu vax hesitancy. Of course, you know, the medications, so the understanding of the role, the benefit, the different effects, whether there was good stock at home, having scripts, and ensuring that the asthma action plan was actually in her preferred language for home, and that she could actually do some teach back around how she would put that into place and escalate. Checking the inhaler technique, stressing the importance of that in relation to, you know, when they're having 1 puff of Flixitide, to make sure that puff counts. And I needed to address the kinder refusing his attendance, and just, you know, sort of on a minor level, well, until it was spring, seasonal hay fever and managing his eczema. And so
Deb disappeared for everybody else.
Yes, she has for me too. She might be logging back on. In the meantime, I think Stephen posted a question around whether the action plan needed to be color. Is that, I think, the question? I don't know what your others. We've been gifted a color printer. There's only just one in the whole hospital. And so we have got away with black and white. Has that been an issue for others, having to have color action plans?
I've not had that for a while, but certainly schools and daycares like color-coded things, but it's not a requirement, and they are not allowed to refuse a black and white. So I just say no. And leave it at that, really. I have a letter that it was sort of common things that are refused. Someone also said, why was he refused?
Yeah. And why was he refused? I think, Kirsty, you cut out a little bit. I think reading through Deb's slide, I think they can't refuse a child with asthma, but perhaps in this scenario, they haven't felt that they had the equipment or the plan to respond to his clinical needs. And that may be why, because I think in my experience, if my kids don't have the puffers and inhalers or they're out of date, they can refuse. Yep.
Yeah, we had a session with the Department of Education. So you're not allowed to refuse a child attendance to an education facility because their plan is out of date. And that is healthcare inequity, and you can email the Department of Education or provide the kinder with the email to clarify that. But if you don't have crucial medications, for example, epilepsy medications or Ventolin, then I think they can until those medications are there. So if the asthma plan is not ready by the beginning of term, the child can go to school, they can go to camp. They're not allowed to refuse it if they have a plan and they have the medications, because a plan does not dictate clinical care. But if your child has just had a seizure or just had ITU attendance, and you come and you don't have an asthma plan and you don't have medication, I would consider that's actually pretty unsafe. You do need to you do need to provide life-saving medications with your child if they have a life-threatening illness. And someone said to the child that they do want coloured copies. People love coloured copies, but they don't need coloured copies. So there's what people want and what people need. And Livia said, yeah, it's great for things, but if you don't have a color printer, then you know it's it is what it is. I think there's another question here just about somebody had said about the latrines and the slide I showed as well. Yes, no, don't use them PRN. You agree, Catherine?
Yeah.
It's on or off. You're on them or not off.
Correct.
Apart from anything with side effects and everything, it's too hard. You either need it or you don't need it, and not as required. And I think I liked showing that because it's tricky. and we don't have a paediatrician and 20 other asthma healthcare professionals to discuss it with when we're in clinic. So keep those questions coming. I think that's it. Have we lost Deb
No, I'm
completely?
back. I'm sorry, my screen just went completely black and I'm plugged in. Anyway,
All right. Let's carry on.
I'm mortified, but I'll be very quick.
It's not your fault.
Sorry. So of course the thing that we all do as health professionals in a short period of time is build rapport and trust. And, you know, we try to go slowly. We are clear and simple. You know, we definitely, you know, check understanding. And I did call the Children's Hospital and confirmed they were on the waiting list for allergy referral, made sure they had the correct contact details. Discussed influenza and asthma, and Mum was happy to go ahead and have the flu vaccine. Got her to get all her medications out, all her scripts, and make sure that one by one she knew what they were, how to use them. And I think we do take for granted that people understand a script has repeats on it. Not everybody really gets that concept well. The asthma action plan, she did have a copy in Arabic and then one, you know, which she gave to the kinder. The kinder was interesting because the asthma action plan had been filled out, but didn't have a signature nor a stamp. So I provided a spacer mask for them. We took in the stamped, signed asthma action plan, and then the barrier then was that they wanted the Ventolin that we gave to actually have the child's name on it. And so then, you know, wrote a note. Dad went off to the pharmacy, had that put on, and then went back and we established, right, are there any more barriers? No, we could go back to kinder. So I visited Mum weekly for the first few weeks, and then second weekly for the next month, and then we went to phone monitoring with her. And it was about 2 weeks after he'd had really good adherence to the Flixitide that Mum felt she could see a clear difference in his asthma, and said, you know, he was sleeping better, he was waking refreshed. They did go off and see the GP and have the flu vax, got another script for Flixitide. That asthma action plan was fixed up. And I find it really valuable to speak with, sometimes we don't get to speak to the GPs, but the value of practice nurses to say, this family are coming. These are the things that, can you make a note that they need to cover off. The other thing I'll sometimes do is send the parent a text with things that they can sit and show the GP that needs to be a prompt to sort of tie off. And Mum returned to English class, and at that stage it was 2 months down the track and he'd had no further ED attendances. Katie, my colleague, and I actually went into his medical record a couple of days ago. And he did have a presentation in February this year, but it was actually for an injury, not for asthma. So since we got involved, he hadn't had any further ED presentations. So just that quickly, the next slide, that final slide, is about before we discharge, you know, trying to do a comprehensive review. And now that we've got ICAM and MAGIC to, you know, try and cover off those medication, asthma action plan, GP linkage, primary care, inhaler technique, and, you know, sort of the community asthma, they can actually reach out if they need to after we've discharged them. And you've probably seen in that last slide, put, you know, highlighted GP all the way through. So really good linking with GP, primary care, and for them to understand that asthma is a season by season, year by year thing, that with conjunction, good relationship with a GP, it can be well managed generally in the community. I think I'll stop there because I know time's against us.
Thanks so much, Deb. I'm sure people won't mind going over a couple of minutes. Any questions for Deb? I think she's highlighted brilliantly just what the HARP and the community asthma programme can do for your asthma patients. It's the extra time, the value they add, the experience, a different viewpoint, hearing it from a different healthcare professional. I find it's a really holistic approach to asthma care. I'll let your questions keep coming in. We just do our usual housekeeping at the end to let you know about health pathways. There's a lot of confusion in the slide I put up, and the reason I put it up, because it's confusing. Guidelines can be confusing. If you are wanting to know what you do locally, health pathways, the RCH, I always put a mention in here, is a really easy one to see what you're doing. It's much more streamlined, more complex than the GINA. It tends to be workable, as opposed to what's the cutting edge of evidence base across the world. So health pathways, acute asthma in children, 12-year-olds and older, 6 to 10, 1 to 5. All these pathways that you can look at, they are really useful. Whether it's, I've not actually seen an acute asthma attack in a 6-year-old before, what do I do? Or it's chronic cough in children. Okay, really useful there. Oh, and you can get CPD hours for health pathway usage. That's new to me, so you can log it as well. Okay. Accessing health pathways, you can use that barcode there, QR code, sorry, still stuck in the 90s. And a little bit about community asthma programme. As Deb said, the HARP programme is similar to the community asthma programme, just in case anybody doesn't know about it. It's DHH funded. It is expert asthma care led by asthma nurses. It's a free service. They are seen until they are discharged. They have got great communication links with GPs and hospitals. There is an integrated referral form. If you have best practice in your offices, just go into letters and look for community asthma programme referral. Otherwise, if you Google community asthma programme for your area, you'll get the numbers in which to put a referral into and guidance on how to do a referral. I think they've even got a downloadable referral form. And just put the poll up, Nikki. So we're just keeping an eye on referrals to community asthma programme, and appreciate if you could just fill in this quick poll.
Kirsty, I might just say that for our Western Health at Home referrals, ours are generally in-house. So they come from ED, the children's ward, outpatients. Some families do self-refer. If they've been on the program before, they'll make contact. And occasionally we'll get someone refer from a school or a maternal child health nurse.
That's fantastic. Thanks, Deb. There we go.
We've only got 3 responses to the poll, so if anyone else would like to add their answer.
In the interest of time for everybody. Our next community of practice, we don't have a date yet, I don't believe, unless anybody who's at the last working group can tell me the date. But it's likely to be, what are we in May? I think August. Your feedback is valuable to us. If you could click the link to give us a survey about how you found this evening and any ideas for future working group or community of practice, let us know. All the information and recording will be emailed out to you afterwards. And if I could just ask any member of the working group just to stay on for a little minute, that's the cue to do the survey.